Hello all, I am Dr. Vipul Sharma.
I am Dr. Sadhna Sharma.
Today we are going to deep dive into HPV vaccination in females.
Yes, you chose a very good topic to throw light on. Recently, Government of India is contemplating to introduce vaccines in National Immunization Schedule for girls.
You know, medical advice is usually so black and white. It's clear, do this, don't do that.
You are right. Get your flu shot, don't smoke. It's comfortable because it is simple.
Exactly. But today we are diving into something that is squarely in the messy gray area.
We are talking about the HPV vaccine, but specifically for adults.
Right. That kind of 27 to 45-year-old crowd.
It's a really distinct category. If you are younger than 26, the guidelines are very clear. Get the vaccine. It's a public health, no-brainer, no question asked. Take your vaccine, it's compulsory.
But then you're 26 and it's like the rule book just vanishes.
And it gets replaced by a conversation.
That's what I found so interesting in these sources.
This whole concept of shared clinical decision making, which I'll be honest, at first it kind of sounded like a way to say, well, we don't know, you figure it out.
I can see why you would think that, but it's actually much more nuanced.
It's the medical community admitting that a one-size-fits-all approach just doesn't work for this group.
Because our personal histories are so different by that point.
That's the crux of it. It moves from a simple checklist to a really personalized risk assessment.
So, our mission today is to unpack that. Why does automatically yes suddenly became a maybe at age 27?
And what are the actual factors you need to discuss with your doctor and make a good decision for you?
Because it feels like this is less just about biology and more about, I don't know, probability.
Yeah, it's absolutely probability game. And to really get it, we have to start with what the vaccine actually does and what it doesn't do.
Right. Because I think a lot of people think of a vaccine as a sort of reset button, like an antibiotic.
Yeah, clean the slate.
Yeah, I might have been exposed, so I'll get the shot to fix it. But the clinical guidelines is crystal clear on this.
It's preventative, not curative. The vaccine stops you from getting new HPV infections. It does absolutely nothing for an infection that you already have.
And that's where the age thing starts to really click into place, isn't it?
It is. A 12-year-old has almost zero chance of prior exposure. A 35-year-old, well, it's a very different story.
But wait, I'm looking at the natural history section in our sources, and it says most HPV infection just goes away on their own.
Yeah, they do in a year or two for the most part. Your immune system clears it. It's very effective.
So, if I was exposed at 25, isn't it probably gone by 35?
Yes, mostly. But this whole conversation isn't about the infections that clear. It's about the ones that stick around, that persistent infections.
Really?
Yeah, the one that hide out and can decades down the line lead to things like cervical cancer or throat cancer.
Decades? That timeline is it's terrifying. You're not talking about getting sick next month. You're talking about preventing a cancer that could show up when you are 50 plus.
Yeah, it's like biological time travel. A decision today to stop a process that takes 20 or 30 years to play out.
And the vaccine has to get there first.
It's a race between the vaccine and the virus. And for the most sexually active adults in that 27 to 45 group, the virus has often already won that race, at least for one strain.
So you would be vaccinating people against something they already encountered?
Which is why the benefit of vaccinating everyone is lower. The utility just isn't there across the board.
Okay, this brings us to what I think is the most mind-bending part of the whole topic. The paradox of risk.
I like that name for it.
Yes, because it really flips your intuition upside down.
Right.
You would think that a person with, let's say, high risk profile, more partners, that would be the ones who need the vaccine most.
Exactly.
But the guidance seems to suggest maybe not.
It's a tough bit of immunology. That person the one with more risk factors is also far more likely to have already been infected with the HPV strains the vaccine covers.
So the horse has already left the barn.
Yeah, the horse has left the barn. Since the vaccine can't bring it back, its benefit for that person is pretty limited.
So then you have the opposite person. Someone who say 35, maybe just out of a very long-term monogamous relationship, very few partners in the past.
On the paper, they look low risk.
But they might actually be the perfect candidate for the vaccine in this age group.
Because they are what we would call immunologically naive. Their immune system probably hasn't met these viruses yet.
So for them, the vaccine works just as well as it would have been at age 15. It's protecting a clean slate.
That is the aha moment. The best candidate isn't always the person with the most risk in their past, but the one with the most potential for the new risk in their future compared to quiet past.
So let's talk about that future risk piece, because in life a lot of change can happen between 27 and 45.
Yeah, a marriage can end. You can find yourself back in the dating world.
Which means the shared clinical decision making conversation has to get pretty personal, doesn't it?
It does. But a doctor can't run a blood test to see your 5-year plan. They have to ask.
So where do you see yourself romantically becomes a valid medical question?
It has to be. Look, if you are 40 and you are in a stable monogamous marriage you expect to continue, your future risk of a new HPV infection is basically zero, right?
So probably vaccination doesn't make much sense.
Yes, but if you are 40, newly divorced and downloading dating apps for the first time in a decade,
then biologically you are entering that risk pool.
And in that situation, there's a really compelling argument for vaccination. Even at 40, the virus doesn't care about your age. It just sees a new opportunity.
The sources also talk about patient values and preferences. That feels very subjective for a clinical guideline.
It is, and it need to be. Think about that newly single 40-year-old. Maybe the data says their benefit from the vaccine is moderate.
Okay.
But maybe they have a lot of anxiety about health, or a friend who had cervical cancer. For them, the peace of mind might be incredibly valuable.
So, even if the raw medical benefit is small, the psychological benefit could be huge.
Precisely. And if that person understands the limitation but says, I wanted to do everything I can, that's completely valid choice.
And so is the opposite. I assume someone saying, you know what, the risk is small, low enough, let me pass.
Right. As long as it's an informed decision.
That's the key.
The goal isn't to get one right answer. It is to get the answer that the patient understands and feels confident about.
Okay, let's switch gears. To the practical side, let's say you and your doctor have this talk. You weigh everything and the decision is say yes. Then what are you actually signing up for?
Well, it's not a one and done shot, and that can be a barrier for some people.
It's a series, right?
Yes, a 3-dose series over 6 months.
Walk me through that timeline.
So you get the first shot on day 1, we'll call that month 0. Then you come back 2 months later for the second dose.
Okay.
And then the final dose is at the 6-month mark. So you start in January, you're not fully protected until July, and you really do have to finish all the 3.
And what about safety for this specific age group? Are there any extra precautions or concerns?
Honestly, the safety profile is incredibly well established. You have the usual stuffed sore arm, maybe low-grade fever, but the serious side effects, they are extremely rare. There are no special warnings for this age group.
And what about pregnancy? 27 to 45 is a prime time for that.
That's the one major contraindication. The guidance is very clear. If a patient is pregnant, you should delay the vaccination until after the pregnancy is completed.
So you just hit the pause button on the series. You don't have to start over.
Exactly. You just pick up where you left after delivery.
As we walk through this, I keep thinking about how much it relies on the patient being completely honest.
Yes, it requires a level of honesty that can definitely be uncomfortable.
Yeah, if you downplay your past to the doctor, because you're embarrassed, you might talk yourself out of the vaccine that you could really benefit from.
Or the reverse, you might talk yourself into the one you don't really need. That's why they call it shared. The doctor has the medical knowledge, but you, the patient, have the context. You have to merge the two.
Shared clinical decision making is really just a code for an honest, maybe an awkward conversation.
That's the only way it works.
So, as we wrap up, the main takeaway seems to be that this decision for this age group is all about weighing your past exposure against your potential future risks.
It's a negotiation, really. You look at your past honestly, you look at your future realistically, and you see if there is a gap where the virus could still get in.
And if there is, the vaccine is a great tool.
And if there is not, you can feel confident skipping it. And either choice is the right one as long as it is informed.
Which brings me to the final thought I want to leave everyone with. We keep talking about how these persistent infection can take decades to become cancer.
A really long time horizon. It's hard for us to think that way.
It is. But it means the decision you make at 35 or 40 isn't really for you of today. It's a decision you are making for the you of 20 or 30 years from now.
You are sending a biological care package to your future self.
Exactly.
It's not just about immediate health, but about your whole life trajectory.
Well, hopefully, this deep dive gives you a toolkit you need to have that conversation.
Thank you for listening, and we'll catch you on the next deep dive.
Bye bye.